welcome to yet another episode of the Health and Wellness Show. My name is Chabet Birir na kama kawaida, this is where we inform you, we empower you and inspire you to take charge of your health and live your best life. Now today we are talking about antimicrobial resistance, a topic that many of us don't understand, but it equally affects all of us. And that's why we have experts on set today to help us understand what antimicrobial resistance is and how it affects you. Now, to my extreme left, we have Dr. Lois Ombajo, who is an infectious disease expert and also a lecturer at the University of Nairobi. She teaches medicine. Karibu sana, daktari. We also have Dr. John Kariuki, who is a veterinarian and also a person with lived experience with antimicrobial resistance, and he'll help us understand how he experienced it and how he is now championing against antimicrobial resistance. Karibu sana, Dr. Kariuki.
Thank you.
Now I want us to dive right in, starting with you, Dr. Kariuki, with your lived experience. How did it start and how did you know that this was antimicrobial resistance?
Thanks very much. This started sometime in 2020. It was actually October the 6th of 2020 when I had accidental slip and fall in my bathroom, and that occasioned a fracture of the hip joint. It was initially very, very painful, and I could not even get out of bed for 3 days. But on the third day, I went to hospital and I underwent examination. But there was an initial misdiagnosis, whether there was probably a mix-up, because I was advised to take muscle relaxants and painkillers and go home. But the pain persisted, and so I had to seek a second opinion, and I went ahead and did a CT scan, which showed very, very clearly that there was a complete fracture of the hip joint. Now, the recommendation was that I undergo surgery to put in an artificial hip joint and also stabilize the surrounding bone with plates and screws. So it was agreed, and that was done on 25th of November the same year. And then it was a 4-hour surgery. And after that, I was sent to the ward to recuperate. After 1 week, I was released to go home. All the while, I was on antibiotics and painkillers. And I was released to go home, and I was requested to come back after 1 week for dressing. And even when I came back after that 1 week, there was still a lot of pain. But the belief was that time will heal as I took antibiotics. But then immediately after that, I never recovered. I continued to deteriorate. My health became so bad, and a few weeks later I was brought back to ICU. Of course, now I have what the medics call septicemia, infection in the blood, and it was taking its toll on me. So again, I was given antibiotics in ICU and stabilized, and then put again in the ward for another 3 weeks. During these 3 weeks, of course, I'm on antibiotics, very heavy antibiotics, and a negative, what they call a negative pressure machine, which was to suck off the fluid, the discharge from the surgical site. And this continued for about 3 weeks, and a day before Christmas of 2020, I was released to go home. Still very unwell and still on antibiotics. But the health continued to deteriorate. And then I remember I sought advice from several orthopedic surgeons and several physicians, and it was agreed that I go to another orthopedic hospital where I could be attended to. But even in that hospital, they were unable to attend to me because they didn't have hospital bed space. And I remember that night I slept in a nearby motel, and by morning all the beddings and towels and bandages and clothing were all soaked in discharge from the surgical site. Then the hospital said I was almost facing kidney failure, so they referred me to a referral hospital. and I was taken to that hospital the same evening, where again I faced the problem of bed space. But luckily, after a short while, I was able to be admitted to the high dependence unit in a semi-conscious state. So I was stabilized again there and released to the ward to recuperate. All the while I'm on antibiotics, I'm on body fluids that into my veins. And after about a month in hospital, I underwent a second surgery, now to remove the artificial joints, the artificial hip joint, and the plates and the screws in an effort to try and control the infection that was not going away. So I remember the orthopedic surgeon who did it proclaiming that he'd never removed dead tissue from a human body while in his career in practice. So it was quite a lot, you can imagine.
Yeah.
Then after the surgery, I went again back to the ward to recuperate, of course on a wide range of antibiotics, very strong antibiotics. But still the infection seemed not to go away. It could go down, but not go away. And then unfortunately, in April of that year, while I'm in hospital, I still got COVID infection, because that was the advent of COVID. And it was a very bad experience. Yeah. It was adding salt to injury.
I can imagine, and you're really strong. You
already
survived.
Yeah, already you're immunocompromised, you're weak, and then you get COVID.
Yeah.
But this was because the virus was flying around, and that was the time it was really spreading. But I managed to get out of it, and by the following month of May, I was released on a stretcher to go home. So I went home having lost about 30 kilograms of body weight, extremely fragile, and now I could not even walk. I had to get a full-time nurse to stay with me in my bedroom and do all the things that nurses do to patients, patient care.
Okay. Thank you, Daktari. Yeah. We have an hour. I know you will continue to tell the story, but let's allow now Dr. Lois to explain to us what exactly is antimicrobial resistance, or AMR.
Thanks, Chebet. So maybe I'll start by talking about how some organisms cause infections.
Yes.
So when people if someone has an infection, and infections come in various forms. It could be an infection in the lung, what we call pneumonia, an infection where the bacteria is in the blood, what we call a bloodstream infection. It could be an infection affecting the urinary tract, so the kidneys, the bladder, so we call that a urinary tract infection. It could be in the tissues or in the joints, so we'd call that skin and skin structures, the structures that support the skin, underlie the skin. So we'd call that a skin and skin structure infection. Occasionally, like in Dr. Kariuki's case, it can happen where surgery has been done. So we call that a surgical site infection.
Yes, because in Dr. Kariuki's case, he went to hospital with a fracture, not
Yes, he went to the hospital with a fracture. The skin was intact. But the minute you cut the skin, then you can introduce infection. So usually these infections are caused by bacteria. Remember, different sort of organisms cause different infections. So like you mentioned COVID, those are viral infections. So viruses can cause infections, examples being things like COVID. Many of the colds and flus we see are caused by viruses. HIV is a virus. But you can also have bacterial infections. So the infections that I talked about are caused by bacteria. So the way we treat bacterial infections is to give an antibiotic. And I'm sure people know a few antibiotics. You've heard of amoxicillin, azithromycin. Those are antibiotics, and they kill bacteria. So the way bacteria live, it's almost like a human body. If there was a threat towards you, you'd find a way of defending yourself. You'd set up some defense mechanisms. And bacteria behave the same way. The antibiotic being the threat, they change some components about them. It could be the receptor on the wall of the bacteria that senses the antibiotic. It could be something about the structure. And they set up changes within that act as a defense mechanism against antibiotics. So what that means is that the antibiotic can no longer kill the bacteria. So we say the bacteria has become resistant. So that's what we refer to as antimicrobial resistant. It can happen with other organisms. Viruses can become resistant to antivirals. Fungi can become resistant to antifungals. The biggest threat that we're dealing with is bacteria being resistant to antibiotics.
Yes.
We have other examples. Malaria can become resistant to antimalarials. TB can become resistant to the drugs we use to treat TB. So that whole component of resistance is what we call antimicrobial resistance. Yes.
Now we'll talk about how now they come about. Is it caused by human beings, animals, plants? We'll talk about that.
Yes.
But thank you so much for explaining it to us. Let's now get back to Dr. Kariuki. Now you've been discharged. This is in May 2021?
Yeah, 2021.
Yes. I would imagine that the amount of money you spent, I mean, you were going to treat a fracture and then you end up treating an infection that is just not going away. So how much did it cost you?
Roughly around $35,000 US.
That's about how many Kenyan shillings?
That time it was about 3.5 million.
3.5 million shillings.
Yes.
To treat an infection.
To treat to the whole course, and even without getting better, the hospital bill came to that. But you know, I had not recovered. I recovered at home after I took measures to do what we call a culture and sensitivity testing, which is basically I engaged a laboratory, a good laboratory, and they were able to get some sample from the site and then culture it in the laboratory and isolate the organism that was causing the mayhem, and then expose it to 18 different antibiotics, out of which only one was effective. And that is the one antibiotic that we used to treat myself at home.
At home?
Yes.
All right.
Yeah.
So then this means that the economic impact of antimicrobial resistance is huge. I mean, Dr. Kariuki would have spent less money were it not for the resistant...
Yeah, sorry for interrupting you. The irony is, when those results came, the cost of that antibiotic, the cost of treating me for 5 days with that antibiotic was a little less than $50.
Wow. Okay.
Purchase of the drug, purchase of the syringes and needles to administer, it was less than $50.
$50.
And if you compare that with $35,000, that is money that would have been constructively used in the community or somewhere else, if the right thing had been done.
If the right thing had been done.
Yeah, which is what we did with the laboratory.
Okay.
Yeah.
Dr. Mbajo, how does it come about from humans to animals to plants? How does it intersect?
Yes. So I think let's start with humans, because I treat humans.
You treat humans.
As I said, bacteria exist generally. All of us have healthy bacteria, normal bacteria on our skin, in our mouth, in the gut, you know, along the airways. So there's a lot of bacteria in the body, and this coexists with us peacefully. The problem is when we keep taking antibiotics, and this is, I think, a very common situation. Someone gets a small sore throat, they run off to the pharmacy, they buy antibiotic, you know. Hospitals are also culprits. Someone goes in with something mild that's viral, but they end up with a prescription of an antibiotic. Someone keeps antibiotics that worked last year, and the next time they feel something coming, they take an antibiotic. And commonly, someone has a tummy ache, a tummy upset. You know, they're having diarrhea because they ate something they shouldn't have eaten, and they're rushing off to get an antibiotic. What that does to you is that this normal bacteria in your body that is there coexisting with you, it aids in digestion, for example, now begins to set up what we call the defense mechanisms against antibiotics. So you end up, we say, selecting for resistance in bacteria that would normally sit in your gut. And usually what infects you is what is in you. So when you begin to get this resistant bacteria in your gut, the next time someone has a urine tract infection, it's a resistant bacteria. The other danger of this resistant bacteria is that in hospitals, you know, hospitals is a lot of people are not well, their immunity is not so good. We're using a lot of equipment, there's a lot of touch, surfaces are being touched. So this bacteria also stick to these surfaces. They're spread by hand because of, you know, examining, a lot of contact. So this resistant bacteria then begin to multiply. And you can imagine they're more common in hospitals because there's also a lot of antibiotic use in hospitals. So someone would go in for a procedure, and other than the procedure, if they got an infection, it's more likely to be than a bacteria that's resistant, because that's what is in the hospitals. So from the human perspective, one, it's largely because of how we use antibiotics, but there's also spread within hospitals. When we think about animals, and this is now a very important aspect, there's a lot of antibiotic use in animals. Someone says, oh, the chicken is sick, they run off, they buy doxycycline, which is an antibiotic that's commonly sold, and they put in the water, so all the chicken take this antibiotic. Or someone hears there was a sick cow in the neighborhood, and there's this fear that, you know, whatever will spread, so everybody's running to give the cows antibiotics. So there's a lot of antibiotic use in animals. But animals also have bacteria just like humans, which means you also then end up selecting for resistant bacteria in animals. And when we consume these animals, when animal excreta contaminates environments, when we drink milk that has antibiotics in it, then we can also get that. And a lot of resistance is actually because of excessive antibiotic use in the animal sector.
Yeah, and I like that, because also we've had cases of farmers, and Daktari, you're a vet, so you can explain this better.
Yeah.
Injecting chicken, for example, with drugs to fatten them. I don't know if you've experienced that with animal owners, and how does it affect antimicrobial resistance?
Yeah, first of all, remember, a chicken is a small bird.
Yeah.
It has no musculature to do injections, first of all, and that is why most of the preparations for veterinary use in poultry are oral based.
Okay.
You either put them in water, or you put them in the feeds, so that you medicate the chicken. So issues of injecting chicken with that's normally, those are stories.
The stories.
Those are stories.
Okay.
Yeah, the easiest way to administer drugs in poultry, for instance, is through the oral way, through drinking water, or even medicating the feed. But as she has elaborated, the use of antibiotics in feeds and water in an excessive way contributes to development of resistance, and is one of the drivers of development of resistance. Yeah.
Okay.
Yeah.
Let's now come back to human beings. Dr. Ombajo, you talked about self-medication or over-the-counter medication with antibiotics. But there's also the lack of finishing a dose, where I buy antibiotics, I'm supposed to take them for 5 days, I do 3 days, I stop. Does it also contribute to resistance?
So before I answer that, disclaimer, it's important to finish what your doctor started.
Yes.
The danger, though, is if I went off to the pharmacy and bought an antibiotic for myself, I'm given, take this for 5 days, but I had a viral infection. And just to mention, 99.99999% of all, you know, all those infections are viral, which means the antibiotic is not helping me. If I like this common joke that if you take an antibiotic, you'll get better in 7 days. If you don't take an antibiotic, you'll get better in 1 week. You know, so it doesn't matter whether you take the antibiotic or not.
7
so
days,
in that case, if someone stops it, I'm fine with that, because you didn't need it in the first place. However, if I gave you an antibiotic because you have a urine tract infection, for example, like many women may end up with an infection in the bladder, I give you an antibiotic and you need to take it for 3 days. We want you to take it for 3 days, because it's not just that you'll get resistance, but you will not get well. You may get complications because of a poorly treated infection. So for the sake of proper treatment of the infection, take the full course of the antibiotic.
Take the full course of your antibiotics.
Yes. But maybe just to add, the other dangerous thing that we see is, so someone goes to hospital, and we see this with mothers a lot. And they say, no, last time my child was sick, they were given ceftriaxone. That's some injectable antibiotic that's very common. So they feel that every time the child is sick, they have to be given that, even when the child doesn't require. So they really put pressure on the healthcare worker to give them. Or they take an antibiotic and they keep it. You know, you've taken it for 2 days, the child is better. So they keep the remnant, and 1 month later, they come home with a running nose, they give them for another day. 1 month later they come home with a cough, they give them whatever was left. So other than exposing this child to side effects of these antibiotics, taking expired drug, for example, it means you're also just exposing this bacteria to just a little antibiotic every single time. So with time you end up selecting for a lot of resistance as well.
All right. There's also the case where for antibiotics, if I was unwell, the reason why people don't finish their doses is I take it for 1 day, 2 days, I feel I'm okay, and then I stop. What would you say about that?
So that's dangerous in many ways. One, if you really did have a serious infection, so let's say, and I gave you the example of someone has a UTI. Yeah? So it's a partially treated UTI, but if it was just in the bladder, if it's only the bladder that has an infection, treatment is fairly easy. But these infections can, what we say, ascend, go upwards towards the kidneys, where then you get a more severe infection, can damage your kidney, which has very major consequences. So partially treating an infection is not good because you end up with complications of that infection. So importantly, we want to make sure if you do have a bacterial infection, it's well treated with the right antibiotic and it's completely treated so that you avoid complications.
Okay. Daktari, now what would you say were the challenges that came with the resistance of infection, resistance to drugs in your body?
Well, first of all, you can see when one antibiotic is used and it's not working, they'll tend to change to another one.
Yes.
And so on and so on. And this really challenges the kidneys, your body functions, because the kidneys are challenged with excretion of the drug. The liver is also challenged because it has to metabolize that drug. And, you know, generally you have a deteriorating body condition. It is not good to take a myriad of antibiotics. You're taking this one, it doesn't work, you begin to take this one. There's also something called drug interactions. Some of those drugs cancel each other when you're using them. So it doesn't help much. And it goes further to complicate this issue, this condition. And as Dr. Mbajo is saying here, in summary what she's saying, abuse, misuse, overuse of antibiotics is are the major drivers of antibiotic resistance.
Okay. Yeah. Thank you so much. We are going to take a very short break, and when we come back, we'll talk about how to prevent it, how to stop it, and what we can do as a country and, of course, as a continent to stop antimicrobial resistance. Don't go away. Welcome back. If you've just tuned in, this is the Health and Wellness Show, and my name is Chebet Birir. We are talking about antimicrobial resistance, also known as the silent pandemic. Why? Because it is killing many people, yet it is difficult to point the root cause of it. You'll find people dying from kidney disease or liver disease, but when you look closely, it's because they were resistant to a drug. And on set with me, we have Dr. Lois Ombajo, who is a infectious disease expert, rather, and she's here to explain to us how to prevent it, how it comes about, and what we can do to stop antimicrobial resistance in Kenya and also in Africa. We also have Dr. John Kariuki, who is a veterinarian and also someone with lived experience with AMR, and he's just explained to us how he acquired a resistant infection, and also what how it affects plants, animals, and of course human beings. Karibuni sana once again to the show. Before we went on a break, we were talking about the challenges that come with AMR, the effects, and I would just want us to also talk about how to prevent it, because Like I said, the World Health Organization take. Ilikuwa imeflow. Kuna mahali nimekwama. Aya, take anti. Nianze from the top. Nianze to how to prevent AMR. Okay. Before we went for a break, Dr. Kariuki was explaining to us how the AMR has affected Sawa. Twende tena. Milon, niende. Usinyamaze sana. Sawa. Before we took a break, Dr. Kariuki was explaining to us the challenges and the impact of AMR on his life. And we would like to just understand how to prevent it and how to stop AMR. So, Dr. Lois, how can we prevent AMR?
Before I talk about prevention, I just wanted to paint for us what is the actual picture of AMR in country.
Yeah.
And we have been doing a lot of work, what we call surveillance, to get an understanding of what is the extent of AMR in our hospitals in the country and how is this contributing to mortality. Because at the end of the day, what we really want to ensure is that people get sick and get well without excessive complications or excessive cost. And what we found in our work is that at least in hospitals, most of the bacteria are resistant to antibiotics. So as an example, the bacteria that causes urinary tract infections, and I keep mentioning it because it's an important and a common infection, particularly in women. The commonest bacteria causing urinary tract infections, almost 60 to 70% are resistant to the common antibiotics that you use in the outpatient setting, which means we now have to start thinking about which antibiotics do we need to use. We find patients who have, skin infections. There's a very common bacteria we call Staphylococcus. Again, Staphylococcus, almost 50% are resistant to the infection, to the antibiotics that we use in the outpatient setting. That means now we have to use intravenous antibiotics. You have to be in hospital for a long time. So that is a scary thing to think about, because it means that if I got an infection now, chances are the common antibiotics will not be able to treat me. So we have to think of more expensive inpatient hospitalization. In the country, we've had situations where there are outbreaks of infections in newborn units, for example. So you can imagine a unit full of children, you lose maybe half of those children because of a very common bacteria, and it's becoming common in our hospitals, called Klebsiella. So it's something that we cannot afford to just hear about. It can affect any one of us.
Absolutely.
And it also doesn't respect
class.
No. You could be the most expensive private hospital, or you could be in a very poor public hospitals. We find resistant bacteria in all hospitals. It doesn't respect class or money or insurance or whatever you have.
Okay.
We have had situations where a patient comes in and they require ICU admission. So think about the cost of ICU admission to treat a pneumonia, for example. And there's situations where we have to even import a very expensive antibiotic, and there's no guarantee that it will cure that infection. So we really have to think about this. It's truly a silent pandemic because we're losing a lot of lives.
Yes.
We're currently doing some research and looking at mortality that's associated with resistant bacteria. And what we're seeing is that if someone has an infection, or all the people who had an infection with a resistant bacteria, about 60% of them died. So it's not something that we can afford to not
be
prevent.
silent about. Yes.
So that's not to scare us. That's to say we must do something to prevent. And that was really your question. What can we do to prevent?
Yes.
So it's very multi-pronged. It's a multi-pronged approach. So one, we talked about abuse, misuse, overuse of antibiotics. We bring a lot of resistance to ourselves. So First, for everybody, do not take an antibiotic without a doctor's prescription. Do not go to the pharmacy and buy an antibiotic over the counter. And I know I've stood behind someone in a chemist who said, nasikia uchungu sana nikimeza. And immediately they were given Augmentin, you know.
Or
azithromycin. You know, those are very common.
Yeah.
Azithromycin became very common during COVID. So avoid doing that. You may think you're going to get relief, but remember what I said. If you have an upper respiratory tract infection, whether you take the antibiotic or not, it will go when it goes. You know, it will take a few days and it will finally go. So protect yourself first. So that's for us as people who use and consider using antibiotics. The other thing is about pharmacies and chemists, because we are responsible for what happens to people. If someone is selling an antibiotic without a prescription, then we're really harming each other.
Yes.
And this goes to farmers as well, you know, about just giving antibiotics to flock and animals all the time, because that translates to humans. So that's the first thing. It's around how we use antibiotics. And I think it's also a call to government to regulate antibiotic use, particularly the over-the-counter sale.
Yes,
because if we don't do that, we're losing this battle. So that's one. The second one is within hospitals. Infection prevention and control. Remember we said these things are, it's how all these high touch surfaces, it's spread between patients in hospitals. So really making sure things like, basic things like hand hygiene, washing hands, cleaning hands. And even for us outside, we talk about prevent an infection so that you do not have to treat it. You know, think about washing your hands so you're not getting a diarrhea and running off to get an antibiotic. Wash hands so that if you've touched droplets from all people's homers, you're not infecting yourself. So prevent infections so that you don't have to treat them. Some things require vaccination to prevent. So where relevant, the relevant vaccines, get them so that you're protecting yourself from infections and you don't have to start treating those infections. So that really, in a nutshell, is sort of some of the most important things we can do to reduce what we're already seeing.
Okay. Thank you so much, Daktari. Now, you've reminded me of a research that was done in hospitals that we have flies actually causing AMR. So that's true, right? It can happen where, you know, maybe a fly goes to your food and you eat the food and it has the resistant.
I think when you see things like flies and cockroaches in hospitals, it's a reflection of the cleanliness of the place, you know. And if we're not cleaning sufficiently, then of course you're going to have a lot of infection spreading. When you go into a place and everybody has diarrhea and some of those are taking antibiotics, they're really just driving this pandemic as we speak.
All right.
And remember also, hospitals, just to add on what Dr. Mbaji is saying, hospitals is where you have all the antimicrobials being used in vast quantities. And we have organisms that have become used to those environments where antibiotics are, are very, very common. And so these organisms, they are called nosocomial organisms. They live in hospital, and you can imagine how resistant they can be. My infection was brought about by a nosocomial organism because it's an infection acquired in the theatre. So these are bacteria that have lived in hospitals among, inside medicines, and they've gotten used to this. So one of the things that that should be done is surveillance. Surveillance, taking up samples from all those surfaces Dr. is talking about and culturing them and seeing the kind of resistant patterns that we are developing. Remember, bacteria can also impart resistance to each other. One bacteria can conjugate with another one through a process called plasmid transmission. Plasmid are short chromosomal elements that carry the gene that is imparting that resistance. So you can have a bacteria that's not resistant, but because of its affinity with another resistant organism,
teamwork.
They like each other.
Team up against
so we as professionals, she's talked about we as the populace, what we should do. We should not buy antibiotics over the counter. We should get prescriptions done properly, and we professionals should also opt to use narrow spectrum antimicrobials rather than broad spectrum antimicrobials.
What do you mean by narrow and broad?
Narrow spectrum antimicrobials and antimicrobials that work on just a few microorganisms. Broad spectrum will work on a broad range of microorganisms.
So for example, if I go and tell the pharmacist I suspect
Yeah.
I have a throat infection or an upper respiratory infection, they give me a general antibiotic. So you mean that is wrong?
Yeah, that's not right. In fact, what should be done, the correct way to do it, we as professionals, would have to take a sputum swab, culture it and see what is there, and then use the antibiotic that is correct.
Is relevant.
You're not going to take chances and guess that this antibiotic is probably going to work.
And maybe just to add to that, so one of the things that we have in country, and we've done a lot of work around ensuring we use the right antibiotics. And there are national guidelines for antibiotic use that will be developed based on what we see from hospitals. So the encouragement for all healthcare workers is really to use guidelines that are evidence-based as opposed to just picking whichever antibiotic is there. But I feel that if I was a patient, I'd probably be a difficult patient, so to speak, because I demand to know why I am being given an antibiotic. Why am I being given? Have you done a culture? And I think it's also time for us as sorry, I'll speak from both sides because I could be a patient to demand better accountability from our healthcare workers.
Absolutely.
Why are you giving me an antibiotic? Many times patients will come to the clinic and say, oh, I had a very bad flu, I was given this. I was told I have an infection in my blood. It's a very common statement, but we need to demand more from our healthcare workers. Why are you giving me an antibiotic? What is it that you're treating? Have you taken a culture? He kept referring to a culture. So if someone has an infection, let's say it's a urine infection, we want to take some urine, to take it to the lab. It tells us this is the bacteria causing this infection and these are the antibiotics that will work. That means that I'm giving you the right antibiotic early, not waiting until it's not responding. That's when I'm going for another one. So that's an important thing. But the other call actually is to government as well. In this country, there are only very few hospitals that have the capacity to tell you that this is a bacteria and these are the antibiotics that will work. And so there has to be a lot of capacity improvement in the country for our health facilities to be safer places for us, to be places that offer optimal care for us.
Thank you so much, Daktari. So do not take over-the-counter antibiotics.
Do not. No.
Do not. Make sure that if you have to take an antibiotic, it is prescribed by a doctor, a qualified doctor for that matter. Now, we have talked about humans. Let's now talk about animals. And Daktari, you're a vet and also director at the of vet services at the Ministry of Agriculture and Livestock. So how prevalent is AMR among livestock and pets in Kenya and also in Africa?
Yeah, remember, about 80% of the diseases that occur in humans also are transmitted through animals. Diseases like tuberculosis, diseases like salmonellosis, gastrointestinal infections, and things like foodborne zoonosis. We call them foodborne zoonosis because animals provide us with meat. They provide us with milk. They provide us with eggs. Honey is provided by the bees. A bee is the smallest livestock. And all these things are prone to infection. And these infections, they'll come to us when we consume these foods. So there's a very thin line between human and animal health as far as microorganisms are concerned. And some of those microorganisms are still not taken seriously. I can give an example of Campylobacter. Campylobacter is a commensal in warm-blooded animals. It lives at a high temperature, and that's why it's very common in chicken. The body temperature of a chicken is about 42 degrees. That is normal body temperature.
I didn't know that.
If you got 37, 38 degrees centigrade, you'd have a fever. So the chicken will be able to, the bacteria, Campylobacter, will be able to survive comfortably in a chicken. And once it's transmitted to you, then you develop some very serious complications, including joint pains, very painful neuronal conditions. Now, this Campylobacter, for instance, if it becomes resistant and you get infected, then you're going to suffer from the same AMR complications. So, and that is why the approach to combat AMR is in a One Health nature. One health meaning we include the environment, we include the plants or the crops, then we include human health and animal health, because they are all intertwined.
Okay.
Yeah.
And do you have the numbers on AMR with animals in Kenya?
Well, that's a difficult statistic to take, but you know, we are doing, as Dr. Humbajo said, we are doing a lot of surveillance work in the laboratories, both veterinary laboratories and human laboratories. I think we have been funded by Fleming Fund to try and develop data on the resistant patterns that we are seeing, and this data will inform actually on which organisms are becoming resistant and how they are becoming resistant, and which ones occur in both animals and humans.
Okay.
Yeah. So that work is ongoing.
Okay.
Yeah.
All right. And do you have regulations for farmers in vet practice on how to use antibiotics?
Yes, we do. First of all, there are those drugs that must be prescription-only medicines. They should not be administered by anyone. They should be administered by a veterinarian or under the supervision of animal health professional. Sorry. We also have guidelines on biosecurity. She talked about infection prevention and control. And in order to avoid using antibiotics, we had rather promote biosecurity, so that then we reduce the need to use antibiotics. So we have biosecurity guidelines for farms and for farmers.
Okay.
And I'm not hesitant to say that most serious farmers are very serious about biosecurity, because they don't want to lose their investments. They're normally heavy investments, and they are very careful about biosecurity. But we want everybody who wants to engage in life sciences to get to understand what biosecurity is and what infection prevention and control means as far as combating antimicrobial resistance is concerned. Yeah.
Thank you so much, Dr. Now, Dr. Humbajo, do we have groups of people who are at a higher risk of having AMR than others in the society?
Yes. So probably not at risk of having AMR, but at risk of more severe outcomes from AMR, because AMR can affect anybody.
Okay.
But those who are in hospital, so anyone who's hospitalized is at high risk of getting what we call hospital-acquired infections. And as I mentioned earlier, hospitals tend to have more resistant bacteria than outside there in the community. So hospitalization, but we also have people who are at risk for infection. So someone who has their immunity compromised for whatever reason. They could have diabetes, for example. They could have some cancer that they're dealing with, and they're getting treatment that suppresses their immunity. Newborn
HIV.
children,
Yes.
you know, HIV that's not treated. If the HIV is well treated, we don't have an issue. But if they're not on treatment, then that's an issue. Newborn children, because their immunity is not well developed. People who have kidney disease, for example, and are undergoing dialysis, for many reasons. One, their immunity is not as good, but they're also in hospital a lot. You know, they're going in for dialysis twice a week, spending significant amounts of time in the hospital environment. So anyone who has some of these comorbidities would be at higher risk for getting an infection, and infections acquired in that hospital environment are more likely to be resistant to antibiotics than infections acquired out in the community.
Okay. That's a good one. So, Dr. when it comes now to vets, we have farmers who go for drugs because they're cheaper and they can't afford the most expensive drugs, which now are the recommended ones. How would you advise them?
Yeah, I would advise them to either go to the vet school and do the right education, or to consult the professional veterinarian. I know most of them want to be vets, but none of them wants to go to the vet school to learn pharmacology, toxicology.